Okay, thanks for your patience, everyone. First, I'd like to introduce Piruz Huda. Huda has worked as a psychiatric nurse practitioner since 2001, with the majority of his treating population being older adults. He's co-authored an evidence-based dementia care training program with Dr. Linda Terry with the UW School of Nursing, and he's made dementia a key factor in his daily clinical practice. Currently, he provides psychiatric assessments, medication management, and consulting to 18 assisted living facilities in the Seattle area. And we're really privileged today to have two excellent speakers. So Karen Clay is the clinical social worker at the UW Memory and Brain Wellness Center at Harborview, where she assists patients and families in maximizing quality of life, providing support, and connecting to community resources. Karen has previous experience on the Harborview Palliative Care Service and worked for hospice for over 10 years. So some incredible expertise among our speakers today. Take it away.
All right, I will start, and me and Karen and I will tag team this. All right, so to talk about care planning and early Alzheimer's dementia. This is a topic that is relatively not talked about much, and there's a bigger need for it now, and I'm glad we're talking about early care planning. This topic is about we're talking about our patient population being those with an early diagnosis. So it's not about their age. It's about, they could be in their 60s, 70s, or 80s. It's about having a recent diagnosis of dementia or mild cognitive impairment. And remember, it's early on. This is our population. So they're the ones that are still driving, living independently. They may still be working, and they're still pretty functional, and they are able to process and make plans for their future, and we're there to help them, right? And compared to 10 years ago, we're getting more patients that are identified earlier with dementia. And so this talk is about us as medical providers, nurses, social workers, part of the health team to help facilitate and support the patient with care planning and following them through the dementia process. Disclosures, I'm just saying that I go to a lot of assisted livings, Aegis and Horizon House, and Karen has nothing to disclose. Learning objectives. I'm going to talk about these topics, uniqueness of ACP, that's advanced care planning in dementia, about what makes it different than the standard advanced care planning that occurs in other diseases. I'm going to discuss the different priorities that occur between providers and patients, and how providers can get on the same page with what matters to the patient. We're going to discuss a lot of important safety and care issues facing people with dementia. We're going to discuss care resources for assisting people with dementia. And at the end, I'll be talking kind of how the rubber hits the road. How do we incorporate care planning into future clinic visits? Now, I'll tell you, this is a fairly, the way I've come up with a way to approach this and talk about this is kind of a novel way of approaching this. So I'm looking for feedback at the end. What resonates with you? We have a lot of material to cover. We don't have time to go into individual cases, which are always a lot of fun. But, you know, with dementia, you know one person with dementia, you know one person with dementia. So talking about first, what is advanced care planning? You know, the traditional advanced care planning revolves around, you know, what we know is it's different than with dementia, right? Traditional, the classic cancer, liver failure, congestive heart failure, is unique in that, well, what it involves is those patients may have identified their durable power of attorney and what their advanced directives are. But the thing is, they're still together and they only have a brief period possibly of incapacity that they're worried about with an imminently terminal event, all right? And the topic is feeding tubes, CPR, right? Ventilators. Meanwhile, when we're talking about dementia, we're talking about something very different. We're talking about this gradual decline in health and cognition. And during that process, there are many potential interventions to think about, not just those at the end of life. On top of that, capacity to make the decisions may have been lost by the time the disease is acknowledged, right? And then my favorite, the insight and judgment of the patient, their decision-making can literally change as the course of the with the disease process, leading to more uncertainty. It just speaks to, there's a lot more variables. And I know Dr. Amy Thomas a couple weeks ago talked about advanced care planning for dementia and advanced directives for that. And if there's questions about that, I can answer more that are specific to that later. When it comes to the uniqueness of this, also what's interesting and what I really want to hit home is how health professionals and the persons with dementia, PWD, the persons with dementia have often different focus and different priorities. When it comes to what health professionals are thinking about when they think about their dementia patients and what they want them to be ready for, we're thinking about, are they taking their meds right? Are they eating right? Are they safely cooking? Are they having falls at home? Are they having issues with wandering? Are they taking care of themselves, right? And if this is really early dementia planning, chances are these issues aren't a big deal right now because it's early on, a recent diagnosis, and they're still functional, right? Meanwhile, the person with dementia who is living with the disease have a different set of priorities about the disease. Well, from surveys, we found that they're worried about losing their job, their finances, their social isolation, the stigma of the disease, their mental health. Tangent, if I can just say, people always say that in the early stage of dementia, people have mood changes. I want to emphasize that mood change is tied to their recent diagnosis. A new onset, a new diagnosis of dementia leads to all these mood changes because they're going through the grief of dealing with this disease. They're going through denial, bargaining, anger, depression, hopefully acknowledgement, and those are the issues. And the biggest one is their fear of being a burden. Being a burden is the biggest worry that people with dementia go through. And the problem with what we need to know is that worry will drive them to procrastinate getting to advanced care plan, right? Planning for this future, their worry about being a burden will drive them to just put off. And we need to get them to be aware of this. This is what matters to them. And by connecting with what's important to them, we can help them better. To talk more about what people with dementia are thinking about, often they're worried about stigma. And in a series of town halls back in 2008, this study is indicating people aren't thinking about when they ask them what concerns them about disease, what was their experience, surprisingly a lot of feedback came back indicating their frustration with the medical system. This is some of the feedback people said with what's important to them about the disease. Quote, "My doctor just kind of cut me loose. You have dementia and there's nothing that can be done. Goodbye." Quote, "People shy away from me. They're reacting like I have body odor." Quote, "People don't know how to talk to me, even though I was the same person I was 5 minutes before I told them I had it, like I was stupid or couldn't carry a conversation." Quote, "Something that's really important, as I want people to understand, is I want to still be engaged with things. I want to have social activities." So people talked about their desire to advocate, to improve their quality of life, and their frustration with the medical system, How do we address these things? These are the issues that are important to the patient, and how do we reach them? Preparing for this talk, I'm a mental health provider working with people with dementia. And the big tool that we use, our way of reaching patients with dementia, is through psychoeducation. It's more than just medical information, teaching them things. It's about connecting with what's important to them. As Dr. Thielke said in his first lecture, to know how to help the patient is to think about what they are facing. Think about the person with dementia, not the scientific basis. The ways that we can connect best with patients is through psychoeducation. And this is a wordy diagnosis, but look at the second half of it. It's about taking the information and integrating emotional and motivational aspects, the approaches, the strategies to enable the patient to cope with the illness, to improve its treatment adherence and efficacy. AKA, we want them to buy into what we would like, what we know would benefit them, right? Psychoeducation is the tools that we use for dealing with health behaviors. And health behaviors are things like smoking, exercise, substance abuse, things we want patients to make positive behavior change. In this article, Sussman, look at it, December 2020, how topical, indicates that advanced care planning is a health behavior with dementia, that we need to motivate patients, know where they're at in order to foster positive behavior change. So to really frame this, one, we need to know what matters to the patient. Two, we need to connect them early with what they need to know because they just don't know what they don't know. And three, from connecting with them, we can maximize better collaboration and decision-making and do things to improve their quality of life and be safer. To talk more about what matters to the patient with dementia, what matters to them. This is what matters to them. The Alzheimer's Association has highlighted what matters to the patient with dementia when it comes to their diagnosis. Now, this might throw providers off. It has in the past. It is telling what patients want from their diagnosis. And this may seem like a lot, but just think about this. Just like any disease, such as diabetes or cancer, what do they want to know? I'm going to read these out, okay? The patient wants you, provider, to talk to them directly about the disease, to tell the truth, to test early, explain why you're testing, to take their concerns seriously, to coordinate with other care providers. I don't do a great job of that. To give them tools for living with the disease, to work with them on healthy living, to recognize they're an individual, and to advocate not just for their medical care, but for their quality of life, you know? And this is, I was talking to a friend of mine who's a social worker with the Alzheimer's Association in the past. And I said, I just found this on the website. This is really interesting, really important. She said, you idiot, this has been up for 15 years. Alzheimer's Association has been trying to get medical providers to recognize this is what matters to the patient. All right. And by not acknowledging it, we are, the patients are tuning us out because they're not getting what they need. I mean, here's the example. This is a direct quote that's from the education material that came with this. It's a quote by a social worker. Quote, I'm appalled still about the abandonment at every stage along the way for people with Alzheimer's. The essential experience is that one gets the diagnosis of mild cognitive impairment and the advice is, don't worry, eat well and exercise. Here's the Alzheimer's Association pamphlet. See you in 6 months for another round of testing. Families are literally sent, in my experience, out in shock. And I have to say, this is still occurring. My patient this past week, I asked her, how did it go seeing the neurologist? She was a patient who I was treating for psychotic symptoms. She saw the neurologist finally. She received the diagnosis of Alzheimer's. And I said, how did that go? She said, well, my mom cried about it. And he just told us there's nothing that can be done. I said, did he give you any handouts? No, he just told us, just sleep well, eat well, and come back in 6 months. And that's it, right? There's a lot we're leaving on the table. This is a key moment, obviously, where the provider could make a huge impact on setting the stage for better collaboration. Now, to talk about how to do that, what's the upside, right? Because doctors are always like, just like this doctor says, there's nothing that can be done. Well, there is a lot that can be done. They're asking for help with quality of life. I want to highlight that. What is quality of life? This can be overwhelming. What can we offer the patient? We wish we can reverse this disease. We can't, right? But what I want to remind providers is that when it comes to quality of life, it's definitely more than possible to live well with dementia. In fact, most patients with dementia are rating themselves, and the caregivers are reporting that their quality of life is good or excellent despite the challenges. It means that we are adaptable. Wow, that just happened. That we are adaptable to the changes that come upon us, and this plays out with me all the time. Is I see that my patients in memory care, in assisted living, I only am referred to see about 10% of those patients. I'm treating for dementia, agitation, anxiety, paranoia, depression, but most of them are doing well. 90% of the patients there are doing just fine. The reason they're doing well is care meets them at their need level, okay? They are not treading water, unlike our patients that may be fighting what they need to do, and they're treading deep water, living at home, not being able to manage. We have a role to play in connecting them with that, okay? So one last thing I want to say, another thought is simply to talk to your patients about preparing for dementia is like preparing for retirement. Those that get ahead of it, are planning for it, have more success with it. It's the way to look at it. Now, to quickly say that the dignity of risk, just know, hey, if COVID's taught us one thing, Americans and all of us in society are big fans for letting people make bad healthcare decisions, right? And we can't, if we get into a fight with them, they're just going to dig their heels in more. So pick your battles, know that battles both sides lose. We best to motivate them, to work with them, to collaborate, to find shared goals. Oh, fearless leader here. One thing I'll say also about, as dementia progresses, this is we're talking about early stage dementia, right? And I'm sorry, early dementia planning with the early stages. And during the course of their care, their dementia is going to progress. They're going to shift in their ability to understand. We need to shift with them, right? Our care needs to align with them across the course. And we're going to get through better communication. And on that, I'm going to turn it over to Karen.
All right. Thanks, Huda. And I'm going to attempt to share my screen here.
I tore through that. All right.
You did. All right. How are you all able to see my slide okay? And is my sound all right? Thumbs up from Huda.
Yeah.
Excellent. All right. So thanks so much for that, Huda, and that real emphasis on that collaboration and importance of language and framing. Just like Huda said, I think that one of the things that is really important in the early stages is really getting some kind of basic things in place. And in particular, making sure that your patients have their power of attorney in place is a particularly important thing because of the fact that, as Huda mentioned, obviously people are going to have progression, and that's going to make it, we just have some window of opportunity to do that. And I am going to, I know that you all out there, are already familiar with power of attorneys, forms, and the importance of them. So a couple of particulars that I wanted to focus on for this group. I do think that for our folks, many of these realistically are a lot older, maybe elderly, although we have seen people in our clinic in their 30s, but by and large, this is an older population. And so when you think about their power of attorney, we want to make sure that there are, that they also have alternates, especially if their loved one is also elderly, or at risk of dying, or also having cognitive issues themselves. So making sure that there's a power of attorney with a healthcare decision maker as well as an alternate is really key. If you are just checking in with your patients to see whether or not they already have that, and they say, oh, I've got it, it's good, make sure that they've looked at it. Sometimes these are forms that have been completed, 30 years ago, 20 years ago, and things might have changed by then. Another thing that's, an incredibly important thing is to say, make sure that you've actually told your power of attorney that they are your power of attorney, and to talk about those things that are important to you. That's key at every place, and making sure that that's a person that you trust would be able to follow through on your preferences. Another side note that I wanted to say too, that it's really important for both the healthcare power of attorney and the financial power of attorney. For your information, in Washington state, they just reinterpreted the way through DSHS that they are understanding who can agree to resources for them. So for example, what is happening at our hospital, Harborview Hospital, as well as other places in Washington state, would be that if a person didn't fill out a power of attorney, then their legal next of kin cannot sign up services for them. So if you have a patient who ended up having a sudden event, ends up in the hospital, then their loved one could potentially not be able to sign them up for services to get them placement. And that basically means that people are then sent to need to follow through with guardianship, which is incredibly expensive, incredibly frustrating. And really, it's just I think it's a sign of our our wacky healthcare system. So making sure they have both that healthcare and finance forms in place is super important. You know, as Huda had mentioned, that we're talking about care planning in early dementia, and again, really focusing on the fact that, you know, we want to be getting from our patients what's helpful for them, and using that information about their values to help us change or focus our recommendations for things that will meet them. And we also heard that patients are really wanting to get tools to live healthier living. And you know, they want us to coordinate with other people. So keeping that in mind as we are working with people over time and thinking about the best ways to support them. So one of the things, you know, as Huda had mentioned, that a lot of people are worried about this idea of being a burden on their families, kind of worrying about the cost of care when they need it. I think that's also something that's reflected in the family members, where they're also worried about that. And it sometimes comes up in the early stages, although it doesn't always. So for some people who are like, you know what, I'm a take it one day at a time kind of person, you don't want to be focusing on saying like, let's get this plan in here now, especially if it's somebody that has resources. The truth of the matter is that there are a lot of different resources that are out there, and it's honestly pretty complicated. You know, I've been a social worker for many decades now, and it's still something that I'm constantly needing to go to, you know, updates about. I'm constantly consulting with my social worker, other social workers, and supervisor. You know, financial resources so care resources and care options are really going to depend on what the person's financial status is, you know, both income and asset. It's going to matter what their citizenship status is, even what their marital status is. You know, somebody who's married can actually have a lot more assets than somebody who is single and still qualify for some of these state programs. And also where you live, not just state by state, but also county by county. There's sometimes more respite services available than in other places. So the messaging for you is that it's complicated. And one of the things that you can really help folks with is that sort of managing expectations. You know, for instance, we don't want to overpromise things, you know, such as we don't want to be telling everybody, including low income folks, that once they have more needs and they can manage it, they can just go to assisted living facility with memory care and get care there, because unfortunately that just isn't available in most parts of the United States. You also don't want to undersell things too, such that there actually are programs that help people in moderate income. And so you wouldn't want to tell people that, you know, you're too high income. So the good news is that there are actually quite a few partners in the community that you can partner with to really help you with those resources. So thinking of them as a partner, you know, Huda had mentioned that, you know, in that study, a lot of patients were saying, you know, my doctor just basically gave me the Alzheimer Association number and said, you know, see you later. We actually want to more think of them as like a partnership and really provide that warm handoff to them. So I'm going to talk a little bit about some of those ways to do that, or know how to navigate that yourselves. When I think about the folks that can kind of help with that navigation piece, there are three big ones. One of them is the local area agency on aging, the Alzheimer's Association, and a publication called the Dementia Road Map. I'm going to dive into the area agency on aging piece. The Area Agency on Aging is actually a national program that basically says we want somebody in each county that sort of knows what the resources are for people that are aging or aging, you know, over 55 or disabled. So it's basically like your one-stop place for sort of what's near me that can help you. And they're also the seat of the places for caregiver support programs. These are places, and when I think about ways to partner with them, sometimes, I think about that messaging that you're using. So if we're thinking about patients who want to know about options for staying healthy, you can say like, great, we have this great idea, the Area Agency on Aging, they offer wellness classes. I think that that might be something that's really helpful to you. It's been helpful to other people that I've worked with in a similar situation. These are also oftentimes people that can help with figuring out legal planning and financial planning. Some of them sponsor legal like seminars with people. There are also folks that can help people navigate that very complicated Medicaid or DSHS paperwork for whatever state or county that you're in. And they can also coordinate with DSHS for helping people with those different programs, which are really complicated. I did just want to point out for the Washington State folks, they just recently added this super cool function, which is on their website, which I have a link on the back of our website for, but they basically make it easy for you to know who your Area Agency on Aging is. So basically all you have to do is go to their website, and then there's this cool button here that just says refer a patient. And this is a HIPAA compliant way to send in information to them. And you can see it kind of goes to this next form. You can see you can identify memory loss, Alzheimer's, wellness programs, nutrition. This is a person who needs a Cantonese interpreter and is early stage dementia. And that actually puts the ball in their court to proactively reach out to the person. And again, that's probably not something for everybody, but I think it is good, especially for the folks that you're a little bit worried about that says they want to have help, but maybe they're having a hard time with organization or motivation. So obviously ask their permission for that too, and get a signature in your own clinic if needed. For folks outside of, Washington State too, literally earlier this week, I had a patient who was seen through our center who was from a small town outside of Coeur d'Alene, Idaho. And literally I just put in their small town. I looked up their county and the word Area Agency on Aging, and right there at my fingertips was the phone number for the Area Agency on Aging of Northern Idaho. And I could just give them that phone number. I printed out the website and handed them on their way. Some of these programs also have brochures. I keep PDF files on brochures, but your local one, since you're more likely probably to be referring to ones in your area, they might be able to give you a stash of brochures to make that handoff easier. Another key resource is the Alzheimer's Association. And again, we don't want to do what Huda had mentioned, which is just say, here's the phone number, see you later. But you want to really think about them as a partnership. So I think, again, that sort of warm handoff of like, this is actually a partner, this is actually a great program that can help with a range of things. One of the things I love about them is that they've got that 24-hour helpline that's staffed by, that has access to master's level dementia social workers and counselors there. And realistically, a lot of our older folks still are having difficulty with technology, especially if they're having some cognitive difficulties. I love the fact that, for sometimes people are just feeling, lonely or sad at the night. There's actually somebody that can call and talk to them at that time. Or else they're too busy during the day and things are stressed up and it's only in the afternoon or, after hours that you're thinking about things. So that's a great resource for people. The website is also just a wealth of information. They do have a section called I Have Alzheimer's for folks that are able to navigate the website pretty well. I appreciate that it really comes from a strength-based perspective. You'll see your messages though there that say, you're not alone in this. These are things that you can do. These are things that are going to kind of help you along the way. So you'll see that, you can trust that those sort of messages are there as part of that. They also have a newly diagnosed packet that you can download for your clinic site. And I think that Huda is going to talk a little bit more about that. So I'm not going to talk much more about that too. The Alzheimer's Association also does have some early stage dementia programs. So in addition to their regular, virtual programs and websites, they do have some specific early stage dementia programming. It's everything's been up in the air for the past year in terms of like what's meeting in place, and some things are on hold. But as we hopefully move out of the coronavirus pandemic era, that we'll start having more things available as well. The Dementia Road Map, this might be a form that you have already come across, especially if you live in Washington. And I think this is a really great form because it really does a nice job of dividing things up. So like if your loved one is, in having these symptoms, mild cognitive impairment or early stage, moderate stage, whatever, it says like, these are things to be looking for. These are things that you can do, and these are resources that can help you get there. I do want to emphasize too, and another nice thing about it was recently translated into Spanish. It'd be great if we have more languages. I'm glad we've at least got that in Spanish now. I do want to emphasize though that this is geared towards care partners. So this is not something that is appropriate to give to patients necessarily, unless they say that they want that, because it really is from the perspective of your care partners, and you want to be meeting the patients where they're at. When I give it to families, when I meet with families during a care conference with patients, I say, this is a resource for your family. You're welcome to read it too. It's going to help your loved one support you better. So kind of focusing on the patient, even when I'm talking about this resource for patients. Another good thing about the Area Agency on Aging, the Alzheimer's Association, and resources like this is that they're going to work together complementarily. So for instance, if your patients are looking for, if they call the Alzheimer's Association and they're looking for things locally, the Alzheimer's Association is probably going to look up that Area Agency on Aging contact information for that patient to get more things. So, ideally, we're all kind of working in collaboration to make sure that our patients are getting the best resources and supports for them. Certainly that's the ideal. All right. So, one of the things that we know is that dementia is progressive. As providers, we know that there are realistic safety issues. I formerly worked, as I think Barbara mentioned, that I did work in the inpatient palliative care service, and I did see a lot of the sort of outcome of like when things don't go well. I was really surprised to learn how many of our elderly folks are climbing ladders, end up in the ICU. We also unfortunately see a lot of people who are there with gunshots or with car accidents that are for folks that are cognitively impaired. And I'm thinking, even if you are not working in a trauma center, that you're still coming across issues where your patients may have had difficulty managing their medications. And it is something that really, I think it legitimately just causes us, it causes us distress. Our heart, it can be heartbreaking to see these things that happen to our patients and their families and other people's too. And we want to prevent them from that. So I want to just say, go easy on yourself if you're feeling like, oh, I've got to do something about that, because, I trust that it comes from that. The reality is that we do as healthcare providers often sort of know things that they may not know about how wrong things can go. And just like Huda said too, we want to be not coming at this with like, this is your diagnosis and we're taking everything away because you can't be trusted. That is the opposite of the message that we want to be sending to people. With a new diagnosis, honestly, like unless they're in a crisis situation, the focus shouldn't be on just sort of like the taking things away. It's sort of that exploring about what's important and being aware of the fact that your recommendations for somebody in the early stages is really going to be different than the recommendations at mid stage and older stage. So really just sort of like, stepping back, avoiding that kind of crisis reaction, going deep, and always keep in the forefront, who is this person and what's really important to them. That's good patient-centered care. Certainly in early stage Alzheimer's dementia, the focus is really often on getting good habits in place. I do, the hope is that when you're taking care of those small things in the early stage and getting good habits in place, ideally you're preventing some of the bigger um, potential safety crisis going on. But I'm going to kind of try to dip my toe into a couple of the big ones. Oh, not yet. First, I'm going to talk a little bit more about sort of how to go about negotiating risks for that. This is information from Dr. Alan Power, who wrote the books, both Dementia Beyond Disease and Dementia Beyond Drugs. And I think it's really helpful for just thinking about kind of like providing a framework on how to talk with your patients and families. So the first one is that idea of discussing in detail and, most importantly, including the patient in that conversation. That's the respectful thing to do. It's particularly important for people that are still in early stage. For example, we know that people in early stages, there's evidence to show that actually many of them are having more financial difficulties than the average person in their cohort. And so, talking frankly about the fact like this is a real risk, even in the early stage, we're worried because we see the evidence that people are at more risk of financial difficulties and financial distress. And so let's work together on this. Tell me more about you. When you're thinking about the values of person, obviously taking the person in consideration, a person who, traveled around the world, climbing mountains is going to have a different distress tolerance than somebody who, was really homebody, stayed at home, maybe worked in a library or something like that. So really like expecting that not everybody is going to be as worried about some things or others. Another very important part of this negotiating risk is that making sure that you're allowing for some empowerment. So, when you're thinking about about the financial situation, the early stages of dementia is really when you want to start having good habits in place, and then also ideally having some oversight. When I think about sometimes people may be lacking in some insight about what their challenges are. And again, kind of talking in detail about like, even if you don't know what's happening, studies show that it causes more, that you're at more risk to it. Are you open to having more conversation about this? And would you consider having somebody that you care about looking over? Maybe this is a great opportunity to do something together, have like a patient and son, positive interaction, like we're going to sort of do this together. You can teach him a lot. Maybe we had somebody the other day who was an accountant. It's like you can actually share your own skill and your own strengths by teaching him that. And that went over better than just saying, you're about to lose that ability. You better like plan to sort of give up the wallet. Even for people that are in moderate stage dementia, regarding the financial thing, I think it's still important to allow that choice as much as you're able to. So like, for examples for that one would be to make sure they have like a limited bank card where they could still make some purchases themselves and have that autonomy and independence, but the risk of having more serious financial ruin is there. So that collaboration is sort of like getting that oversight into it. And then in terms of monitoring results, it's really going to depend on what the situation is. But I tell you that there are some situations, safety related, that are particularly important in terms of managing the results and how that looks. But ideally, we want somebody kind of checking on your things over time. But that's going to bring me to my next point, which is I'm going to dive into a couple of the kind of more high stakes safety issues. So one of them, I think that driving in dementia is just a huge issue. I'm guessing it's an issue for you all in whatever capacity you're working with. And it's something that we, it's such a big issue that there's actually going to be a presentation just on this. I want to say it's February 23rd with Dr. Chris Rhodes. And I would definitely encourage you to attend to that. Chris Rhodes is great. I think things that I want to just talk about related to that is the fact that, for many people, driving is huge. We have, especially for our older generations, that idea of like, hitting the open road. It's that sort of sense of identity, that sense of freedom. It's just such an American way to think about things. We hear people through our center all the time, like, honestly, like getting told that you have to retire from driving is actually harder than getting a dementia diagnosis. I mean, it's that big of a deal. So I think that you should expect that there's going to be emotions like that. Like Huda mentioned, this is another opportunity where grief and loss is often coming up, and you will serve your patients well by attending to those things that come up. Of course, they're angry. Of course, they are, they may be scared, frustrated, and kind of honoring that is a natural response to sort of losing that part of your identity is really key to that, to supporting your patients. I do think, language does matter. I think that, talking, kind of normalizing that retiring from driving is actually something that all of us will have to do if we have the privilege of living long enough. And that unfortunately, might be the time for this patient, or might be coming up about that time. But again, just kind of normalizing that it's actually something that we're all going to be kind of facing. With dementia and driving, this is something that you really do need to have a follow-up plan with. And I'm going to kind of defer to Dr. Rhodes to talk more about that, about sort of how that's going to look. I did want to give a couple of specific dementia-related resources. These are two that I that I've used a lot. One of them is the Hartford group, Conversations about Alzheimer's, Dementia, and Driving. They make this available for free for people. You can call for your clinics too. You can call them up and say, I need a couple of free books. I called them up the other day and said, I actually need 50 free books. And they were like, sure, what's your address? So it's a great free resource for your folks. The Alzheimer's Association, I think, also does a good job on their website about kind of talking through the issue. They have a couple of videos for family members to watch. And then the other really important thing too is that we don't want to just be saying, as Huda mentioned, we don't want to just be saying like, we're sorry, the end is here. We want to say like, even though we're saying the end may be here and that, or we don't have like a way to bring back your ability to drive, we don't want you to be staying at home. We don't want you to be, by yourself. We want you to be going out, having a good time, doing the things that you want to do, doing things that are meaningful. So that would potentially be a good reason to contact your area agency on aging to find out near you whether or not there are shuttles that are covering your area, whether or not they have a volunteer program that can get your patients where they need to go. Also for how to connect with disability driving if they're not able to drive. And again, early stage is where you want to start trying those things, trying to get in the habit of using them, getting through that period of like initial resistance to trying something new. Ideally, patients can do that with a family member the first couple of times so that you get used to it. Next thing, I'm going to dive right into another really complex and difficult to talk about issue, which is guns and dementia. The reality is that about 10% of Americans over 65 have a dementia diagnosis, just slightly less than that. We also know that 1 in 3 people with dementia, are likely to exhibit some combative behaviors during the course of their illness. I see so much through my process, just, even people that didn't, that had never had any issues with their family, kind of getting a little bit suspicious. I had a patient who I worked with a couple of weeks ago where he had been a military, guns were really important to him, and he had always locked them up successfully. And then kind of over the last year, he wanted to say, you know what, I actually am not feeling good about things, so I'm going to be keeping that on my dresser instead. And then the other day, the wife called me and said, you know what, we woke up and the gun was actually under the pillow. And neither one of them knew how it got there. And it just really brought home for her, like, something serious could have happened. And, her husband would never intentionally hurt her too. But I think it just was sort of like eye-opening about like needing to have a plan in place. You know, another issue related to guns and dementia is risk of suicide. To the right there is a chart that really details sort of the rate of suicide by age and sex. And so certainly males, especially white males, are having the highest risk of suicide. And we do know that that guns are used about 50% of the time. And research also shows that if you remove easy access to guns, that actually decreases the risk of death. So definitely, you know, a big issue. Another thing about it too is that just like with driving, you know, using a gun actually requires a lot of complex cognitive issues. So even though you're doing some things well, may not mean that you're able to sort of manage guns. And again, early stage is where you really want to be thinking about planning for that. So when you're thinking about talking about this with your patients and families, you know, one of the things to know is there's research that was recently done, like, is it okay to ask about guns? And interestingly, people who don't own guns were like, sure, of course a doctor should be able to ask about guns. But then people that do own guns, it was a little bit mixed. But the majority of people that own guns said it was okay for a doctor to be talking about guns if it was related to a specific need. So not just a blanket one, but related to a specific need, something like dementia is more, people are more open to it. And when you're thinking about how to best approach that, I think this is another thing where context really matters. You know, is this a patient who has guns because it's been a hobby, they collect antique guns? Or is this a person who enjoys hunting with family? Or is this a person who has a lot of safety concerns and wants to make sure that they're protecting themselves and their family? And so that's going to really make a difference about how you kind of talk about that with your patients and successfully. You know, I think again, language, you know, using less inflammatory language, you know, thinking about things like, you know, passing along a legacy. So instead of removing your guns, like, have you thought about creating a legacy for your for a family member? I think that that's a more palatable explanation for people who are gun collectors. You know, sometimes utilizing a trusted authority figure to help this conversation along matters. Sometimes that's a doctor or other healthcare providers. The other day I had a patient where actually his trusted person was not that, it was actually his sister. So really kind of talking with the patient and families like, well, who do you trust on this issue, and utilizing them for this conversation. And again, guns is actually something that you do need to follow through with too. The Alzheimer's Association put together a good PDF on this. It's called Firearm Safety. It's something that I have that I keep handy for families that, you know, identify that having gun ownership. So it's one of those, again, you know, like Huda said, like, it's nice to have a handout so people have a plan. That's one that can be used by your providers too. All right, moving along to a little bit less charged safety issue, the issue of medication management. You know, I do think that most of us are sort of aware of the fact that medication errors are a big risk, even for people in earlier stage. And again, we want to sort of like go with that same philosophy of that we don't want to be taking away things that people are doing well still. We want to support them and kind of build supports and build planning for that. So, you know, if for instance, you have a patient who is living by themselves, it's important for them to live by themselves, then, you know, thinking with them about, you know, actually managing your medications and managing it well is a way to help protect you with your autonomy. It can help you with your mood. You know, if you're not taking your medications right, depending on what they are, that could have a real impact on them. And it can also help you, if depending on your medications, think more clearly. So thinking about, like, again, connecting to that, if a patient is really focused on their autonomy, thinking about like, actually this medication thing is going to help you, you know, be autonomous for longer. And that's important framing for that. You know, we often, you know, in early stage, that's the time for people to be having some oversight to that. So, you know, is there an opportunity for somebody to fill up the medi sets together? So instead of a person doing their own, hey, let's do it together every Sunday, you know, before we go to bed, let's kind of do that. Or I guess it would be Saturday. For people who are in the earlier stages, like MCI, there are some community resources that, or some technological resources that can really help support them as long as they have, the right oversight and they're truly earliest stages. We've had people that have used the MedMinder and Smart MediSets. Unfortunately, these are not available through Medicaid, so so there's a cost associated with them. Some of the pharmacy services that deliver do make that sort of make medication more easily. So you can see in the bottom right hand corner there that you kind of pill pack creates these like packages where you can see like, here's the date, here's the time, this is what I'm supposed to be taking, and sort of working with patients to have like a clock with the actual date on it to sort of like work together with that is a good strategy. There are also some medication apps that people can put on their phones to give medication reminders. Again, we're sort of working on empowering patients where there are, depending what their values are, to sort of meet their goals as it is. And then again, recognizing that over time, we'll probably have to have another plan, and sort of setting that seed to sort of an expectation for a monitoring plan over time. Now I'm going to let Huda jump in with his experience with fall risk.
Yeah, can you guys hear me okay? Karen, do I sound okay? Okay, good deal. So to talk about fall risk, wow. We know that a third of adults over 65 experience a fall annually. The patients with dementia, though, are twice as likely to experience falls. And the persons with dementia fall are 5 times more likely to be admitted for long-term care facilities. So, enough we have our patients that are worried about losing their independence, losing their home, and on top of it, they're the worry about falls. They know, and they're probably reminded is if you have falls, you break something, you can end up losing, being at home, and things that are also associated with fall risk being verbally disruptive, visual perception problems, depressive symptoms, and even caregiver distress are all tied to higher fall risk. I just think it's really important to plant the seed early. When we're talking about early, once again, we're talking about early dementia planning. The chances are they're not having the dementia-related fall coordination issues then, to talk to them about this is part of the disease process, about having worse balance. When I was looking at, next slide there. So certainly there's actions we can do. The things we do that we do for patients that do not have dementia, we're going to review their medications, correct vision, hearing problems, check for vitamin D deficiency, right? And also for older adults, we're also going to see if we can send, I would like you guys, as much as Medicare will allow, to have PT and OT out to the home to assess the area, see how well they're moving and walking around their house, to encourage, and those are just more, of course, eyes on the patient in their home as possible. But another thing is I also encourage you guys to tie the balance issues back to the progressing dementia. There's a huge disconnect I read about how, there's family members who are just not making the connection that, oh, my husband's really healthy. Well, his balance isn't as great, but he still works out 3 days a week. Oh, so-and-so, he still climbed the mountain on his birthday, right? And they're not making the connection about how dementia affects balance. And it's important to, you don't want to make them defensive. And as I'm thinking about motivational interviewing and psychoeducation and about making people think about these things, I think about asking patients how many falls they have is about as useful as asking an alcoholic how many drinks they're having, okay? Is there a different way you could be asking and bringing this up? One way to ask is, just like we asked about alcohol, is how about saying, phrasing it differently? Have you noticed anything different about your balance? Has anybody said there's issues with how you're walking around? Are we finding yourself holding on to things when you didn't before? What can we do? What can we put in place for that? I always think about my patients that refuse to use the walker try to refuse to use the cane. I just think that if we set that up earlier in the process, talk to them about it, maximizing time to hone as long as possible to get them on board with using the walker, even though they say they don't need it now, right? All right, I'll turn it back over, Karen.
All right. So a couple of other safety issues that are common that we're not going to really dive into today. Huda mentioned a little bit about those sort of safety assessments. You know, the wandering issue is really something that is especially important for folks that are in the more moderate stages. And just because of time, we're not able to really dive into that. But I do appreciate that there is going to be another presentation coming up. I think it was the first one in March, maybe, that's talking about elder abuse and financial exploitation. So I hope that you will tune into that to learn more about that topic. As a kind of go home resource, this is a great handout through the Dementia Action Collaborative on safety resources that talks about some of these major safety themes that we've talked about today, and it's available to download online. I've got a link at the back of our slideshow today. All right, so now I'm gonna let Huda take over the reins again. I'm gonna try to stop my share.
All right, and I'm going to take it away. Ew, is that right? Okay, am I up and running? Okay, so to think about how to, we just threw a lot of information at you, and how can you incorporate this into your clinic visits? All right. Remember, we want to respond to what matters to the patient and use that as a bridge to talk about important things that can help be useful to them. So if we're having that visit and thinking about the patient who just is getting diagnosed with Alzheimer's disease, all right, or you're thinking they have mild cognitive impairment, maybe you're talking to them about it. Look, we're going to get you an appointment with a neurologist in 3 months, but right now I see this happening. I want you to read up about, what do you think? I'm telling you, you have Alzheimer's disease. Ask them what are the concerns most about them? What's their knowledge base about that? You might say, my mother has dementia. I didn't like how that went. I hated having to see your visit there. What's important to them about it? And, just like my patient was recently told, they may not be, chances are they're not going to be really ready to get all this information right now that you're itching to dump on them, right? So give them some space, give them a little time. Here's some suggestions. I want something to tell them is, listen, I want you to, I've given you listen, now isn't the time to hit you over the head with this, but I want to see you back in a month or two after you've digested this a bit, all right, to think about it. I want you to tell your loved ones about this, your family, your close friends that can support you. And when you come back next, I want you to come back with a family member or a friend, all right? Notice, I encourage you to be kind of directive about it, not just, hey, could you please invite somebody to come in next time? It'd be really great if they come in. No, this is what you're telling them to do. Bring in someone next time. And tell them, my patients who sit this alone really struggle, and they really wish they would have told others sooner, right? That phrase that doctors often say, there's nothing we can do. Certainly we cannot reverse the disease. But there are things we can do to improve your quality of life. That is reaching them with what they want to know. Of course, they don't know what they don't know yet, right? But talk to them about reaching them there. And, I mentioned that there's this, to connect them with resources. We want them to come back in a month or two to talk about these things instead of waiting for them to describe their next problem and having to combine 2 problems with, progressing dementia as well as whatever medical issue they may make an appointment for. Communicating with the person with dementia, speak directly to the patient. Don't exclude them from the conversation. I know we only have so little time, but they need time to express their thoughts and feelings. Ask them to come back with specifics about what they're concerned about, and ask what the person's comfortable doing. Now, what I'm stating might seem pretty obvious, but the feedback from the patients is this is not occurring, Be genuine, be real. For me, that means using humor, but just be there for the patient to for what is on their mind. Now, at the bottom of this, exclamation point, I should have put 17 exclamation points on this, handout. Patients need a handout. Think about I want you to think about older adults, some with mild cognitive impairment. What do we know about those with early memory problems? They are coping with it by writing notes to themselves. They are making lists. They are underlining things. They are reminding themselves, and they benefit from that because when they're put on the spot, they don't remember, okay? So to give them a handout is a reminder to what you talked about. They need handouts. Now, to talk about a great handout, this is one from the Alzheimer's Association. It's called the Taking Action Workbook. And if you ask, okay, listen, let's talk about the Alzheimer's Association. They do great work, and they're the de facto source for all patient education material. So medical providers are always saying, check out the Alzheimer's Association. So you know what? A couple of weeks ago, I checked out the website, and let me tell you, it's kind of a hot mess. It is really hard to find things on there. In fact, I found this great resource, this great 50-page workbook. All right, it's a workbook that says I have Alzheimer's. That's called what it's called? It's called Living with Alzheimer's, right? Taking Action. And in this workbook, you see it has the principles for dignified diagnosis, what I talked about, how to partner with your doctor, some tips for them. It's good to know, you as a provider, to read this, to know what they're reading about, so you're ready for them, all right? Now, however, what's great about this is even if you go to the website and you try to Google this and search for it, you can't even find it, okay? You can't even find it. I'm giving you the treasure map instructions on how to find it. Go there, click on I have Alzheimer's, know what to do, then click on educated, scroll down, then you'll find it, okay? I've given you specific instructions. It just speaks to how hard it is to find things, all right? And listen, if you've ever worked, like I said, you're working with your mom, your aunt, your uncle, they're in their 70s, you've asked them to navigate a website, it's really hard. So listen, if they are in your office, pull out your laptop, show them the website, make a handout of it. You want to steer them to what is good on the website, one or two things, all right? Because this resource is gold. For my patient that just told me that, for the family member told me that they didn't get any resources, I pointed her to this link. I said, download this, get it printed at Kinko's in color, and get it bound and give it to your mom. And she thought it was so great. She actually, and she appreciated it. You know what she did? She made me 10 of these. Okay. So now I have 10 copies of this to use, because I told her, make them as handout, make them so they're in a binder so I can take pages out, because I'm going to want to use this as handouts. So what you want to do is you want to tell the patient, listen, this is this resource. Now, I'm not 100% sure, Karen, there's another one that I have dementia is a smaller handout than this 50-page bad boy, okay? So whether you can get copies of this, I'm not sure. Check the website, call, ask, okay? But it's really worth getting. Directing them. There's a lot that you have to sift through, but take this. I want you to read through it and come back and talk to me about it. What's important to you? This is super. Listen, these are the handouts. These are pages on the page one. There's a couple pages on the left. On the right side of this slide are things that I came up with. But under things I can do now, if I talk to my patient about falls, reducing the risk of falls, removing the clutter, putting night lights in, okay? Getting the handlebars right, I can just take out this page of the handout that they already have and circle it and give it to them, and it becomes their patient instructions. All right. Think about, like, my patients, your patients. I mean, my patients might not remember what they said to the doctor. I'll say, you saw your doctor? What did they say? Oh, I don't really remember. Do you have the handout? They have the handout. They can find that handout. They are keeping all that stuff. But they're getting that medical handout that is just a bunch of gobbledygook where you can't really tell what's pertinent to them. All right. By giving them individual pieces, it hits home. It's more clear. We were talking about driving. There's a lot to talk about, but this handout has excellent information. To drive or not to drive, a diagnosis means you need to take safety precautions. One phrase to tie with the patient: you can live longer at your house if the safety measures are in place. telling them the disease messes with your balance. Instead of saying mom is having falls, it's saying the disease causes mom to have falls. This affects stigma, and it takes away, it attacks the stigma that they're carrying, right? We want to lower the stigma. We want to say dementia takes away your ability to drive, not that your doctor is as much or your daughter is, okay? Now, this is gorgeous. I love this. Look at how they phrased this from this workbook. Some people with Alzheimer's say, I love to drive and it makes me feel independent. At the same time, we would hate to cause an accident and get hurt or hurt someone else, right? This is putting into play psychoeducational, motivational interviewing techniques. We're getting people to think about what's important to them and how to make sense of the ambivalence, right? So we asked them to fill out their thoughts. How will they, I circled this, to identify when will they know it's time to retire from driving? The person I trust will tell me when to stop driving. These are great things to ask them to be thinking about early. And this workbook walks them through it, right? And then, they have appointment logs in their medication list, because of course our patients, when they go to I love being able to visit patients in assisted livings. I give them a lot more time to come up with what they want to say, because they are put on the spot when the doctor walks into the office. We want them to be ready to ask their concerns. Better they say it now than they forget to say it. With any stage of communication, I'll tell you, listen, ABCs of communication. What I'm referencing there is, listen, there's another talk I have on the archives of this geriatric series. I did a talk on behavior management of addressing dementia-related behavioral disturbances, the psychological symptoms of dementia, right? And the main intervention is behavior management, is identifying the problem behavior and the ABCs, the antecedent, the behavior, and the consequences, right? We need to pay attention to the consequences of what our plan is, what worked and what didn't, okay? So what I'm saying is pay attention to what you said works and what doesn't. This is part of what a patient-centered approach is. One approach, what I mean by that is the patient-centered approach is tailoring the education to what their needs are and what they want, right? And it's different for patient to patient, right? And we don't know what that is until we ask, right? And whether our approach worked or not, we don't know until they respond back, right? The patient, how do you know when your patient doesn't care when you tell them there's nothing you can do and don't give them a handout? They don't show up for the next appointment. That's why, okay? So, getting that feedback on the consequences of what you said, what resonates with them, pay attention to that, right? What I'm thinking about when I want to get them to use their walker, I want to be able to say, it messes with your balance. I like you to be able to stay as long as possible, but if you're having to hang on to things, better you're hanging on to that walker. How to phrase this in a way that's going to be useful. When you're scheduling follow-up visits, I also encourage you, if they're coming back in a couple months, to bring in their DPOA, keep encouraging activities. I looked over why providers have a hard time talking about dementia. And some of them said I'm used to fixing problems as a provider, as a doctor. I want to fix their medicine. I want to fix their diabetes, their blood pressure, get the numbers low. It just feels like with dementia, I'm just doing a lot of hand holding. And the answer is yeah, because that's kind of what they need. And you're kind of the de facto leader on this. And if you're not going to do the hand holding, at least promote what needs to be said. And if you're going to have the patient come in to see the nurse or the social worker, please talk it up. Talk up the importance of making that follow-up appointment and following back up at the clinic about things. And if you do end up hand-holding and just making some statement to be easy on yourself, stay active. There's a handout for that. Okay, like from the page from the booklet, you want, after you have that conversation, circle it. I'm asking you, Janet, to be easy on yourself there, okay? And to stay active, to get involved. We're asking them to do these. This, once again, part one of the handouts from this booklet, right? Print it out. It makes it more real. It's a prescription and it ties back to a handout they already have. It's kind of a callback, because what do we know about people with dementia? They kind of do need it repeated a little bit, and they need it presented in different ways. And that's why handouts matter. You know, and as the disease changes, as the course of the disease changes, we're getting away then, of course, from early dementia planning, and the rubber hits the road as dementia progresses, that this isn't just early dementia planning. This is managing dementia issues now, right? And this might involve having the caregiver in the room, right? And now we're looking at caregiver resources. We talked about the Dementia Road Map, and Karen hit home the Area Agency on Aging. There's an awesome service, this Conversation Project. The Conversation Project, if you have some time, Google it. The Conversation Project, you're going to pull up all this fabulous information on helping people talk to their loved ones about durable power of attorney. There's this great one on caregivers or people with Alzheimer's. And on the right side, there are the questions for loved ones to ask their family members. Listen, if you become sick with another illness, how much do you want me to try? Do you want me to try everything available? Or would you like me to just worry about my comfort? All right. If you're unable to speak for yourself, mom, what do you want to, how do you want to handle this? This is giving them those tools. In fact, there's so much good stuff in there. Like there are parts in that book that prepare the DPOA, the potential DPOA, to talk to because you're going to get those calls, right, about the family member to deal with the patient. What is like, you need to talk to them. The caregiver book, the conversation starter has topics like, what if I feel afraid to talk? What if they insist there's nothing wrong with them? What if they don't want to have the conversation? What if they react negatively or think I'm trying to upset them? You want to know the answer? Look it up. There's answers in that book, okay? So this is all
there's a link to that in at the end
of
our
on the back of the resources, right?
Yeah.
Thank you. And so, yeah, so, that's us as we're following the progress. I just wanted to say, kind of in closing here, where's my last page? Here it is. Karen and I spent some time, we really worked on this because we really do care a great deal about how we can impact patients' lives positively. I enjoy working with patients with dementia because I do see how I can improve their quality of life. And yes, it's a terrible disease, but really getting ahead of this, early dementia planning and partnering with the patient means a lot to the patient, and you can really have better goals made and quality of life can be maximized, right? So I like you to think about this. And, one thing is, as I've laid out this approach for dealing with patients with dementia, it's kind of a new concept that I'm laying out there that I really haven't seen written about. So if you guys end up using any of these strategies, you got any feedback, what works, what doesn't, feel free to email me and let me know what works, because I think I'm going to continue to work on this and try to hone this approach down better. So, try it. And with anything, if it doesn't work, try something else. So Karen, anything else to add?
No, I like that messaging. I feel like it's a process for all of us. And I feel like we all want to do a good job. And some days we're like, yay, that went well. And other days you're like, oh, I wish I would have done that differently. And I think that we just have to kind of get back up and use this knowledge to, and to really try to improve our practices. And I just agree too with the sentiment of sort of the joy that actually comes from working from this population and the connections and quality of life that we see.
Yeah, and one last thing I'll say is like, I work so much with the patients with moderate stage dementia. It's sort of like playing it out. These are the problems they're having. Think about my patient in early dementia, how they're going to be facing this, and walk it backwards and think of what they need to know now to prepare themselves for that, right? That's all.
Thank you so much. This has been just an incredible interprofessional guide to care planning for Alzheimer's disease and dementias. I do have questions starting up, so I'm just going to go ahead and start reading them, if that's okay with both of you.
Yeah, sure.
All right. So the first one is, since the federal rules superseded Washington state law a long time ago, what care options are available for the working poor in terms of this early stage?
Uh, Yeah, so the question is sort of what options are available to the working poor. So it depends on where you live. A lot of the programs that are geared towards the poor are through state Medicaid programs. So there is going to be a difference between your state as to what resources are available. Because I'm based in Washington State, and the majority of our folks are from Washington State, I know that better. But I do know that, DSHS or Medicaid is not the same in Washington State in terms of like the scope of services as it is in other states. Again, contacting your local DSHS office could do that. So, for instance, there are some programs through Washington State long-term care that can provide some in-home care for people who are making, if you're single, if you're making about $1,200 or less and have significant functional needs, and then you can get some limited care in the home. There's a separate program in Washington State that's part of a Medicaid, I think it's transformation project, where you can actually make up to $2,400 per month and still qualify and still have $50,000 worth of assets. If you are married, you can have up to $100,000 worth of assets. So that's in Washington State. The program for moderate folks is called TSOA. The other program through DSHS, we commonly refer to it as the COPES program or Community First Choice programs. And again, it's so complicated. I think, again, that would be a great reason to call your area agency on aging to sort of say, like, tell me what's near me. Because there also can be some like separate for folks that are undocumented or limiting. There's sometimes some separate towns or counties set aside some separate respite funds that can be used to help give your caregivers a break or provide a little bit of in-home care for folks.
Thanks, that's great. Can you clarify a statement made earlier about hospitals are not able to use next of kin for decision-making if they don't have a DPOA, or is that only related to signing someone up for benefits?
Yeah, thanks for that clarification. So usually we think about your legal next of kin as the person that can sign if you're not able to, or make healthcare decisions for you if you're not able to. It's super straightforward. It's really widely accepted. What I was actually referring to is in Washington State, DSHS, which are those Medicaid programs for the folks that have limited resources. They're not allowing legal next of kin to sign you up for those programs. And those are the programs that can provide either in-home care or provide placement. So if somebody went into the hospital, after having a, massive stroke, did not have capacity, if they did not have power of attorney, then their legal next of kin couldn't sign the paperwork to say that I want this person to go to the skilled nursing facility and under the care of DSHS. Hospitals very routinely defer to legal next of kin for decision makers in the absence of power of attorney. So I want to be really clear that that's still available. In fact, in Washington State, we recently expanded the laws about who could make a medical decision based on legal next of kin to include grandchildren, nieces, nephews, and things like that. But it's only for that sort of helping your patients get either placement or care if they're low income. And we're hoping that actually changes and that we're able to go back to using legal next of kin for that, because it's just causing a lot of barriers to getting people the help that they need.
Okay, and then there's a question just asking what year is the guns and dementia slide? I think, what year did that slide cover?
Let's see. Well, the rates of suicide, that was gathered from Department of Health site for the years 2012 to 2016. I got that information from a great resource called intheforefront.org, which does gun research. So I got a lot of information from there. They are a great place to go to for, they're really the experts on sort of gun safety, suicide prevention basically suicide prevention, and they have a lot of information about guns just because that's the number, that's such a big issue for suicide folks.
Well, and so then a related question to that is asking about why suicide might be higher than among white males.
Oh, wow. That is a really good question. I'm afraid I don't have the answer for that. I do know that is, as we saw, that is one of the risk categories. There are other things too. I think that, maybe contacting that organization in the forefront.org might be a good place to know that.
I was just
I don't know, Huda, if you have an idea.
I was just Googling it, and there's theories about it. But I will just say it's just important to know that's occurring, right? It's more just saying, listen, the older white male is the highest suicide risk. It's always been that way. And to just be aware of that, to ask the right questions about their thinking about ending their life, and to just ask the right questions about it.
Yeah.
And then another suicide question is, are the issues of suicide that are here in the US an American phenomenon, or do you know if it's also globally?
Ah, good question. Well, I'll tell you, we're talking about dementia specific right now, right? And then there's outside of dementia, right? Suicide risk. Oh, there is. Well, nobody has access to guns like we have, right? So there is that's the story with suicide. It's about access to the means that we have higher access to. And so I just think that, that is why there's higher numbers of obviously gun deaths. Suicide by gun is ridiculously high. And these things we know.
So you mentioned that persons with dementia write notes and reminders for themselves. What are some other simple ways to support independence?
Wow. Karen, anything? Go.
Well, I do think one of the resources to use would be, oftentimes speech therapists or neuropsychologists do a program called cognitive rehabilitation. So refers to that specialty for that cognitive rehabilitation, to really teaching those skills for getting routines into place, getting the most up to date in terms of like what have been helpful evidence-based data to support, some of these technological trends, things like that. So I think your speech therapist for cognitive rehab for folks in early stage dementia is a particularly good resource. And then I think too, like, some of the things through the Alzheimer's Association are have other good ideas about how to support somebody in early stage to get those good habits in place.
I will say the Alzheimer's Association has excellent material there. It's just hard to navigate. And yeah. I just think somebody with Alzheimer's needs somebody else working with them to try to find the right information.
Yeah, I mean, I do nothing but dementia all the time. And so I actually have I could just pull behind me a whole stack of like my favorite brochures for them, for that idea that it is a little bit hard to navigate. So you can just say like, I've got, ideas for activities of your day, ideas for communication. Here is that slide. And I'll send it as a PDF for folks that prefer electronic versions of things. So having maybe a stash of your go-to, like these are your communication brochures, these are things that you can hand out. Would be a recommendation if you're able to do that. And
yeah, I was just thinking about how if patients can get hold of the whole handbook, and then to keep being able to just remind them with cues of certain pages that are important, because you just can't expect them to bring on all 50 pages each time and remember what you're talking about and go back home and find it. They just need to be cued to what's important at that time.
Okay, there are a couple of people asking about the slide with the resources, but it's showing now, and I put a link at the bottom that takes you back to where the handout is, and the resources slide is on that handout as well. Another question, how do you address depression in dementia while you're working with your patient?
to address it. Well, okay, that's an interesting thing. And when I was looking at these like this taking action workbook, people don't really want to, I think people don't want to just quickly just assume this is depression. There's a difference between addressing depression and feeling depressed, right? And the like I was saying, a lot of this is grief and coming to grips with the disease. And and I think that it's so complicated about how to address that. Frankly, the most important thing to encourage people to do is to stay active and to reduce social isolation. It's and part of dementia early in the moderate stage is losing initiative and not knowing what to do in those states. So we want to get them, how can we make that part of a structured schedule where, you know, what we talk about, increasing pleasant events, increasing things they can do, and having some, is there anyone there that can help cue them to it, right? That's what's so important. Oh, and it's just terrible in all my patients in assisted livings who just don't have things to do. They're like trapped on a cruise ship and being told to stay in their cabin. It's horrible.
Yeah, I agree with that. You know, I spend a lot of my time kind of talking about ways to engage patients, to like including those events. You know, one great website for ways to engage your patients is momentiaseattle.org.
Ah.
And nowadays that's, you know, it used to be kind of Puget Sound's centered for actual activities happening around town, like walking through Point Defiance Zoo or Woodland Park Zoo. But now it's a lot of online activities and things that people can participate in. There are, you know, one of the silver linings to this whole horrible pandemic is that there are actually a lot more resources that are more available to people throughout the Northwest region. You know, things like Music Men's Minds is a great resource that I referred to. And it used to be that, you know, my folks at Mercer Island did great, but nobody else could get there. And now they're actually offering Music Men's Minds virtually every Monday, Wednesday, and Friday, I think from 1 until 2 o'clock virtually. So I have kind of a list of things that people can do to engage with, but momentiaseattle.org is really your setup go-to place for dementia-friendly activities and opportunities for engagement.
That's awesome. I'm writing that down. I've written it down.
Great.
Yeah.
So here's a slightly different question on another area. Do you ever utilize the dementia directive with your patients?
Hey, you know what? Okay, the dementia directive is sort of like, they're like advanced care directives, right? Specific to dementia, right? You know, I'm going to tell you something. I'm a little bit cynical about applying this right now, just because there's so much involved with making sure all your loved ones are on board with it, right? And I just looked up this study, that very study I cited up there involved okay, I want to highlight the Terry's article that no, it's the Sussman article. The article involved interviewing 28 patients and 19 caregivers associated with the memory disorders clinic at Yale, and asking them, and asking about their dementia care planning. They thought that because they were all involved with the memory disorders clinic, that this would be a population that will have completed these, and none of them had. Maybe they had thought of it, but it's just like, this isn't, when it comes to the directives and filling out paperwork, that doesn't actually get things done, especially when it comes to what these. Now, I did look up the directive that the doctor put up there 2 weeks ago, and they're asking similar questions about what you want on any stage of the disease, but it's not dealing with what do you want to do about housing and safety, as much as still, though, feeding tubes and advanced directive care, right? So there's a lot of advanced care planning out there that are laying out a lot of different options, so they're not standardized. But I just think that it's a big lot of questions you're asking the person to sign for, when that really requires even more partnering with their DPOA and those around them. Remember how we always talked about whether it's signing your organ donation or your durable power of attorney. If you're not communicating with your families about this, it kind of goes up in smoke.
Yeah, so a couple things too, and I have to. I'm wondering if you're talking about the one from Dr. Gaster. I think that one of the messages around that is that's actually a directive to potentially fill out before you actually have a dementia diagnosis, that there's more evidence that for people that are actually already having a dementia diagnosis, that sort of ability to do that sort of more complex abstract thinking is impaired once you're getting into the dementia territory. So again, I think that that's really, a lot of push should be to get people to be thinking about filling something like that before they actually have a dementia diagnosis. And then again, once you've got that dementia diagnosis, the focus being on sort of who's your power of attorney, and does your power of attorney, know you as this person who is aware of like what your values are over time. Ideally you filled out one of those before. That'll help guide the conversation. Huda mentioned the conversation starter project that sort of is geared towards people that already have a dementia diagnosis, to help their family members sort of like get to what they think is important. But that's one of the challenges of that, is that oftentimes for folks that already have a dementia diagnosis, some of that abstract thinking is compromised.
Are resources like the Aging and Disability Resource Centers available in all states for seniors and individuals with disabilities?
Yeah, I mean, I have not ever come across one. Like, it's my understanding, I think, that every county in the United States has a designated place. And we do have people coming to our center from all over. And it has not failed me yet to sort of say, like, who is my area agency on aging? Sometimes, it can be confusing because they often don't have that name, area agency on aging, in them. For instance, in Pierce County, it's the Pierce County Aging and Disability Services is their area agency on aging contact. In King County, kind of refers to as Community Living Connections. Again, doesn't have that AAA name in it. But again, the good thing is that you can find out who your local one is by using that terminology in the county that you're in. Yeah, I believe that, so far I have not found one that I wasn't able to get some information on. Even folks in rural Montana, there's a place that they can go to that knows what's available. Sometimes there's limited resources, but one of the things that as I work with folks both in more urban and rural areas, it's like sometimes I feel like even though the urban places have a lot of information, sometimes it's kind of disconnected, and it's hard to sort of know who's doing what, and they're not talking that well to each other. Where when I'm calling people in some of the smaller areas, they are actually like, oh, I'm going to refer you over to John, who actually runs the support group. You'll love him. He's a great guy. So there is, that benefit of, some of the smaller places, really being able to like hold your hand and walk you through in a different level.
A lot of residents were pulled out of communities during the quarantine and moved in with adult children. So Erica is wondering if there's any direction that they could send to children for protection of assets, like children spending resources to cover the parents' costs of living in their home, that sort of thing.
So would you say that one more time? Sorry.
The whole thing or just the last part?
The first part.
Oh, okay. So a lot of residents were pulled out of communities during quarantine and moved in with adult children. So is there any direction or guidance to send to children about protection of assets, like spending resources to cover parent costs to live at their home? In other words, they're putting some of their funds towards covering costs for their parents. Wondering if there's guidance about that.
Yeah, a lot of these programs, when you think about who is applying for them. So if you have a patient who was living in a nursing home or even a memory care or a adult family home on Medicaid, and now they're going home, they can apply for resources for in the home. And it's going to depend on what the patient's income is and what the patient's assets are, separate from the family members. And so there is a program if the patient had, for instance, again, sort of under about $1,200 per month and was living with a family, potentially either they could have an outside caregiver come in or else a family member, as long as it's not a actual spouse, could actually be paid to be that person's caregiver. So that's through, and that would be, you could get more information about DSHS for that situation where people are moving back in with them. It's a little bit more straightforward if their income is low than for people who are, having higher income and sort of like figuring out like what are the programs that could help us in this situation. But I think an important takeaway is that they're looking at the income of the patient, the assets though of a patient and a spouse, but not the children if they're staying with them.
Okay, do you two have time for a few more questions? Are you
I
okay?
do.
Okay,
Yeah,
thank
sure.
you. Do institutions you work with, like ambulatory or inpatient care, have care navigators for folks who are diagnosed with dementia? It's starting to take hold here in Billings, Montana, apparently.
I'm not
Yeah.
sure. Karen, you know?
Yeah, I think, I'm guessing that it's, I don't know. I was going to make something up. I'm not really sure. I do think though that, we do have more focus just in healthcare in general for some like health navigators. And so I think sometimes nurses in clinics are providing that role. I'm at a dementia clinic and sort of that's my role, is to sort of navigate people here. Again, there are in a lot of the area agency on aging, they have a designated, like, this is our dementia specialist to kind of help you navigate things through our program. So the answer to that would be, I think that it is more common, again, thinking about who are those sort of guides and navigators and checking to see if you've got one through your area agency on aging, if you don't have one associated with a medical center that you're with. Some medical centers that have social workers use them in that way. Others are using them more for like behavioral counseling too. So checking with on that too. I wish.
Okay, so
Someday.
here's back to a question about the suicide. What about people who are planning, and I'm not sure what this is, but VSED or death with dying near end of life? Is that considered suicide too in those charts, I guess, that you were showing?
No, that would not be considered. That would not be considered suicide in those charts. It's my understanding from my work in hospice too, that if you utilize death with dignity, then the actual diagnosis that's listed on the death certificate is the underlying cause that of death. And so, you are only eligible for death with dignity if you have a prognosis of less than 6 months. And so it's actually that diagnosis that goes on the death certificate. With VSED is a whole other very complicated situation. VSED is voluntary stopping of eating and drinking. And I will also say through the Dementia Action Collaborative, they're sort of taking on the task of putting together like a legal planning kit. Sort of the short answer is that people with dementia aren't eligible for death with dignity because of the cognitive impairment piece. If they're not going to have, if they're close to end of life, if their prognosis is less than 6 months, then they're not going to have the mental capacity to make that decision. So they would not be eligible for death with dignity. VSED is just is a really complex ethical situation. I feel like I wish I had somebody great to refer you to it. I know that End of Life Washington that's a topic that they talk about. Again, it is more complicated with people with dementia because of the fact that a person needs to have capacity to be able to sort of get assistance with that.
Okay, somebody had mentioned that the resources handout is not the same as the resource handout that's posted is not the same as on this slide. We did get an update to the slides and I think I updated the handout, but I'll check it when this is over and you might circle back to our page to pull down the handout if you've got the earlier version, with my apologies. There is a question about your thoughts on the #1 research need for improving ACP with people with dementia.
Yeah, I was just responding to that, was just that I came up with so many ideas just looking at that Sussman article that I referenced from December 2020. I don't know if it was an article, but I was able to find it on PubMed and from my UW's just to find it. And it just laid out a lot of, that was the article that said, looking at advanced care planning as a health behavior was just, to me, a novel concept that I had not thought of before. I think there's a lot to think about, and we're still literally brainstorming the best approach for dealing with this. So I just think it's wide open on what needs to be researched.
So a final question is, if the person living with dementia decided to pursue death with dignity when they did have capacity to do so, could that be upheld?
No, it has to be, they have to, in order to qualify for death with dignity, they would have to have another provider do an assessment, a capacity assessment. I guess the one exception would be like if you have another diagnosis, like if you have a cancer diagnosis and a MCI diagnosis, then it's the cancer diagnosis that's like the less than 6 months. But you have to actually have capacity when you are applying for death with dignity. Even stating that was what your wishes were, a year ago, were you to get to that point, again, the law specifically says that you have to have capacity at the time that you qualify for it. That's my understanding.
Well, I just want to thank everyone for participating with some great questions. And Huda and Karen, this has just been a great collaborative presentation. Really, really appreciate it. Everyone, I will check that handout to make sure that the most recent version of the slides that I have is posted there. And thank you so much for hanging in there with us, and have a good day. See you next week.
Hey, Karen, I got a bad joke for you real fast.
Thanks,
Okay.
everyone. I love bad jokes.
Okay, it's like that. You said there's a 24-hour Alzheimer's Association call, like you can call 24 hours a day. And I couldn't help thinking about the sundowning calls they get between 4 p.m. and 9 p.m. How those calls just go off the rails.
Yeah, for real. Be interesting to get stats on that. Yeah, Barbara, I also say, like, this has really been an interesting thing to do this. I don't know, we didn't talk about this before, but I've actually never met Huda. I'd never really heard much about you before we got assigned to do this together. But I really appreciated, like, he has coming from the background of nursing as a ARNP, like, I feel like it was good exercise to really hear different perspectives and kind of work out some of the details. So I feel like I really benefited personally from this collaboration.
And likewise, Karen. I mean, it's, especially nowadays, it's just great to connect with a social worker and hear your perspective, because we all have so many different strengths, man. And much appreciated.
Well, and we really benefited from that collaboration as well. So thank you so much.
Wonderful.
You're welcome. Thanks, guys.
Thanks,
Bye-bye.
everyone. Have a nice evening. Sleep well. Drive safe.